Hello, this is Sharisa Fatinos. I'm the Deputy Chief Medical Officer at the Healthcare Authority. And I want to spend a couple minutes today talking about some of the changes that we've recently made at the Healthcare Authority regarding the coverage for patients who have Medicaid for medication-assisted therapy with a focus on opiate use disorder treatment with buprenorphine. During the next bit of time, I'm going to review a couple of things, talk a little bit about the background and need to address opiate use disorder numbers, talk about buprenorphine, the drug that we're focused on for this conversation, describe its benefits a little bit, talk about the federal waiver required for physicians. At this point in time, only physicians are allowed to prescribe buprenorphine, though there are federal efforts to try to expand that to nurse practitioners and PAs, but talk about what's required to be able to prescribe office-based buprenorphine for the treatment of opioid use disorders. Talk about some of the Healthcare Authority activities that we've been doing lately to better address substance use disorders, and talk about some of the changes to the guidelines regarding coverage of buprenorphine at Medicaid. At the end, we'll leave you with some information about resources and tools. So why talk about this, particularly a focus on opiate use disorder? This is not surprising information. If you haven't heard it a lot lately, I'm surprised. But opiate use disorders impact the lives of millions of Americans in the general population. If you yourself don't know someone or a family who's been impacted by a son, a daughter, a parent, a loved one with an opiate use disorder, you likely know someone who does. Persons who are enrolled in Medicaid with fewer resources to start often are at higher risk of developing substance use disorders. And on average, these are old statistics from 2014, about 105 people die every day as a result of a drug overdose. And if you look at opiate-related deaths, they now exceed deaths from motor vehicle accidents in the United States. Clearly cause for an alarm and legitimizing the term the opiate use epidemic. This just shows graphically, at least from the perspective of Washington State, the increase over the last 10 years in the number of hospitalizations and deaths related to prescription opioid use. The good news is that the word about being careful and thoughtful about prescribing opioids for chronic non-cancer pain has gotten out, and there has been some decline both in the hospitalizations and deaths related to opiate prescription related overdose events. That's not necessarily true as it relates to heroin. Talking a little bit more specifically about prescription opioid overdose deaths, for every one opioid overdose death in 2011, there were 12 substance abuse treatment admissions for opioids. There were 25 emergency department visits for opioids, and about 105 people who abused or were dependent on opioids, and then 659 people who are using opioids non-medically. So that one person, when you take a step back and look up, had a huge, it was just the tip of the iceberg in terms of other people who are affected or at risk for having overdose-related events or developing a substance use disorder. Looking specifically at the Seattle area in King County, this shows over the last 10 years the types of drugs that led to treatment admissions. Many folks have more than just a primary drug, but this shows the primary drugs of choice of people who enter treatment over that 10-year period. And what you can see on the top blue line is that people with alcohol use disorders are more often entering treatment than with any other substance. However, as it's pertinent to this talk, if you look at the red line, this is a reflection on the number of users of heroin who have been admitted to treatment for treatment in King County over this 10-year period. And what you can see is the number of persons with heroin use is pretty close to that of the numbers of persons with alcohol use admitted to treatment. So a rapid increase in terms of it becoming a problem in King County, and this is likely replicated across the state. You can see that marijuana is green, sort of a stable, perhaps trend, and it'll be interesting to see now that marijuana is legal in the state what treatment admissions for marijuana look like over the ensuing years. Cocaine rates for treatment admissions have declined. Methamphetamines have stayed about the same since the early 2000s, and prescription opioids are starting to decline. But again, with this decline comes an unfortunate increase in heroin use. Whether or not they're causal is unclear, but it makes one wonder. So what happens to folks when they do go to treatment for a heroin use disorder or opiate use disorder? These three groups of bars show compliance by treatment type. And on the far left are patients who enter outpatient treatment, 60 to 90 days. The middle section shows people who are in intensive outpatient treatment. That's generally 3 to 4 hours, 3 to 4 times a week. And then on the far right are persons who enter inpatient. And really all that's important to note is the colors. The red means that folks weren't compliant with their treatment program, whether they dropped out early, weren't able to maintain and follow the rules of reduced use or abstinence. Different programs vary by what their rules are, but what you can see for outpatient and the intensive outpatient treatment programs, folks who had opiate use disorders didn't necessarily do well in terms of compliance. People who had access to and were able to get into inpatient treatment, however, did do a little bit better in terms of compliance. And these are the total numbers of folks through these treatment centers. So you could say, well, everybody should only have inpatient treatment for opioid use disorder. That may or may not be true, but what this tells me across the system is treatment alone in the way that we're currently offering it may not be enough to help people be successful in treating their opiate use disorders. And why might that be? I think what we've learned over the last number of years, and I think is becoming more, the awareness has increased across circles in healthcare professionals as well as the lay public, is that addiction is a chronic brain disease. It's like any other chronic disease in the sense that it's preventable. We have treatments. It changes the biology in our body. And if untreated, the consequences can last a lifetime, and in the case of drug overdose, become morbid or lead to mortality. If you look on the left, these are PET scans, and on the left shows a PET scan of far left, a healthy brain, and next to that, a person who chronically uses cocaine. And what's important to look at is on the far left, you can see in the frontal part of the brain, nice yellow, sort of orange, almost a hint of red in the prefrontal cortex. This is the part of the brain that is responsible for judgment and decision making, nice, healthy glucose uptake. In this person who uses cocaine chronically, you see that there's less uptake of glucose, less sort of active functioning. And again, this is the area of judgment and decision making. So if that area of the brain is not as well perfused as it were, or working as well in terms of glucose metabolism, kind of makes sense why some folks with addiction disorders aren't able to necessarily make the best judgments. Come over here on the right, this is a heart. This is a healthy myocardium, lots of glucose activity, lots of uptake. This is a heart that is diseased without adequate blood flow, and you can see a similar difference in the reduction of glucose. This slide shows different substances and their effects on brain metabolism. The top is cocaine, followed by methamphetamine, alcohol, with the bottom being heroin. And really the point is to show the uptake as it relates to the receptor availability is decreased with whatever chronic drug of abuse there is. A nice amount of uptake, nice receptors for dopamine that you see in all these pictures are reduced through chronic substance use. So I talk a lot about substance use disorder. I'm not really using the term addict, addiction, chemical dependency. And that's because with the DSM-5, sort of the way in which substance use disorders or addiction disorders were defined has changed. And really it focuses more on the consequence of a person's use of whatever substance it may be, as opposed to just the fact that they may be dependent or tolerant. So if you look at this slide, it shows the different areas in which chronic substance use can affect a person's life. Importantly, and what's new to this as opposed to prior definitions is there's a craving for opioids. In this case, it could be alcohol, whatever drug. But you're using the drug in larger amounts for a longer period than you intended. You're not able to cut back or control your use, and you end up spending a good part of your time trying to figure out where you're going to get your next dose of whatever your drug of choice is, how to recover for it, and then go out and find it again. There's social impairment, whether that's work, school, family, and not just a little bit, but there are persistent recurrent problems as they relate to a person's use. There's risky use, whether it's using in physically hazardous situations, driving would be a great example, or there are medical complications, clinical manifestations that have occurred that don't seem to alone be enough to help a person reduce their use or stop. And then the pharmacological properties are accompanying the other categories, but they in themselves are not a definitional piece of a substance use disorder. In addition to sort of adding the word about craving, you'll also notice that legal complications was taken off, which used to be in the DSM-IV criteria. There's sort of a gradation of substance use disorder from none, mild, moderate, and severe. And that depends on how many of those criteria on the previous page you might fulfill. And really for medication-assisted treatment, as it relates to the prescribing of buprenorphine for opiate use disorder, we're really talking about people who meet the criteria for moderate or severe substance use disorder. So let's take a step back. We're talking about this medication-assisted treatment. We're talking about these medications. Do they work? Let's start with methadone. Methadone's been around a long time. This is a slide that shows people who have heroin opioid use disorder and either get methadone or no methadone. Some of these studies are old, and there are some newer studies as well that were a little bit better done in terms of low risk of bias. But what you can see is that methadone works to keep people in treatment and have fewer morphine-positive hair or urine samples. Morphine is the breakdown product of heroin. So it keeps folks in treatment, shows less opiate use, either by hair or urine testing. People may not report less use, criminal activity may not change, mortality may not change, but really folks can maintain in treatment and show less use of a drug. And that's a good thing. What about buprenorphine? Buprenorphine compared to placebo is beneficial. What the green circle shows here is that they looked at people who were on low-dose buprenorphine, and this is from 2 milligrams to 6 milligrams, and they had better retention rates in treatment. Again, this is versus placebo. If you look at people on medium-dose buprenorphine, which for these Cochrane systematic reviews was from 7 to 15 milligrams, an even higher rate in terms of likelihood of staying in treatment. And then if you look at higher doses, which is anything 16 milligrams or above, again, higher rates of retention in treatment. So methadone's better than placebo, buprenorphine's better than placebo. What about non-medication therapies? There are a number of non-medication therapies. This slide looks at people who had opiate substitution therapy, whether that was with methadone or buprenorphine, compared to people who had buprenorphine or methadone added on with additional counseling. So these are folks who were in opiate treatment settings. They got their daily dose of either methadone or buprenorphine and some supportive counseling that goes along with that, depending upon how much they get depends on where they are in their treatment and recovery. But they compared that cohort to a group of folks who got additional psychosocial counseling. And when they compared those together, they really found that if you look at sort of this top box, that treatment retention didn't differ, abstinence didn't differ, the number of participants still in treatment at the end of follow-up didn't differ, and the number of folks who were abstinent at the end of treatment didn't differ. Now, this is not to say psychosocial interventions don't work. If you look below, you can see certainly that in terms of compliance, psychiatric symptoms, and depression scores, they were better with these additional psychosocial interventions. So I think to me what this helps point out is that we don't yet know the optimal therapy, but what it appears so far to be is that treatment alone without medication is not successful for most people, and that when people do have medication, there are varying pieces that may be important to improve their outcome, but we yet don't have a one-size-fits-all approach that works at any rate. This looks a little bit more at non-medication therapies, specifically psychoanalytic oriented treatments. along with medication therapy versus medication therapy alone. Again, really no difference. And if you look at counseling, whether that's cognitive behavioral counseling or other types of counseling in terms of retention and treatment and opioid abstinence, again, adding these more intensive psychosocial strategies to pharmacologic maintenance alone did not seem to make a difference. These are not huge studies. There's obviously a lot to control for, but again, this points to me to the effect that we don't yet know the single best strategy, and that because every person's different, we need to approach them in a patient-centered way. But what I think is fairly clear from this is that medication is and should be a standard of care for folks with opioid use disorders. This just looks a little bit more at some behavioral interventions, which include contingency management as a treatment, behavioral therapies, and again, really looked at outcomes, whether it was retention and treatment, abstinence, and then folks either continually abstinent from opiates, or completely abstinent at the end of follow-up. And again, this compares the methadone maintenance medications with a little bit of counseling like you might find in an opiate treatment center to more intensive psychosocial treatments, and again, there's really no difference. Well, what about methadone and buprenorphine? Is one better than the other? Should we be directing everyone to opiate treatment centers or methadone maintenance clinics, or should we really be prescribing a medication like buprenorphine in an office-based setting? This looked at flexed doses of buprenorphine, meaning you gave someone a prescription of buprenorphine and said, take as many as you think you need for your symptoms. And that was compared to methadone in similar ability to flex the doses. And really what you found out was that at fixed doses, people started taking buprenorphine when they felt like it and how much they felt like. They didn't really do as well as folks who were on methadone did in terms of retention and treatment. If you look at other outcomes, there really wasn't any difference. So fixed doses of buprenorphine, flexible doses of buprenorphine, excuse me, are probably not as effective as methadone. What about fixed doses of buprenorphine? At doses above 8 milligrams, which is this lower portion here, there's no difference in terms of treatment retention between methadone and buprenorphine, meaning they're equally effective. If you look at lower doses, at least in this 253-person study samples, you can see that methadone was a little bit more effective, or buprenorphine less effective in terms of retention and treatment. So the message here is that really low doses, less than 6 milligrams, are probably not as effective as doses that are 7 milligrams or more. So how does medication-assisted treatment work? It is an FDA-approved medication that can be used in combination with different psychosocial supports to provide whole patient approach to treating substance use disorder. We're focusing mainly on opiate use disorder in this talk. However, there are medication-assisted therapies that can be used for folks with alcohol use disorders as well. And the idea is that the medication reduces the withdrawal symptoms, helps reduce the craving that people have. It activates and blocks the opioid receptors in the brain, so people can regain a little bit of semblance of normalcy and better address the rest of the issues that are either a consequence of their use or may have contributed to their use in the first place. And really aids in reestablishing normal brain function. As we saw in those slides earlier, there is a difference in the way a person's brain who is chronically using substances changes, that stopping that use can help restore them to normal functioning. So what's all this buprenorphine? Suboxone is buprenorphine, it's one of the brand names, and it's a combination therapy that contains both buprenorphine and naloxone. It's an oral therapy, and the naloxone has been added specifically for the reason that it then can't be injected. If you try to inject Suboxone with the buprenorphine and naloxone, the IV route will precipitate withdrawal, and so it doesn't really work. It's not activated orally, so it's not really an issue in terms of taking it orally. Although if you do take Suboxone and you do have opiates on board, you will withdraw as well. Subutex is a monotherapy, that contains only buprenorphine. It is a drug that actually buprenorphine's been around a long time, initially used for pain. It's a Schedule III medication. But the key to keep in mind about Subutex or buprenorphine alone is it's more easily diverted, and it is a formulation that can be injected because there is not the naloxone, which would render it ineffective. Really the only uses for Subutex are in women who are pregnant, though the FDA indications for the use of Subutex and Suboxone are the same. Many providers prefer to use the monotherapy buprenorphine or Subutex form for women who are pregnant. If someone requests the mono form because of an allergy, we have asked that in order for that to be approved, there's clinical documentation of a significant allergy, whether that be in the form of hives, angioedema, or an episode of anaphylaxis. Again, primarily for the reason that it is easily diverted and can by itself be a drug of abuse. This is a busy slide. I'm not going to go through it all, but basically it in summary says there are two types of buprenorphine products, sublingual tablets and film. It must be dissolved under the tongue, not swallowed. Depending on the formulation, it can take from 5 to about 12 minutes for them to dissolve. You're supposed to basically just sit there and not talk or drink. There are some tricks that people may find helpful in terms of getting them to dissolve more easily, whether it's taking a drink of water, eating a mint, tipping the head forward, and different folks have figured out different ways to have the medications work more quickly. If you are treating someone for medication-assisted therapy, you ask them to come in with symptoms of withdrawal, because the way buprenorphine works, if they take it while they have their opiate receptors occupied, the buprenorphine has a stronger binding affinity, will remove whatever opiate they have on their receptors and put them into withdrawal. So you want to make sure that people are actually feeling somewhat symptomatic from their opiate withdrawal before you give them buprenorphine, but then we'll either remove any opiates on their receptors and make them go into withdrawal, or we'll block them and relieve their withdrawal symptoms. And usually people say within about 20 to 30 minutes they start to feel better at their induction. And then during maintenance, the recommendation is to take a single dose daily. I think I and a number of my peers have found in practice that people do like to, at times, take their dose twice daily rather than all once a day. So what do you need to do to become a buprenorphine provider? First of all, there is a training requirement. You can get the trainings in person or online. Online says it's about an 8-hour course, but it probably doesn't take quite that long to complete. You have to complete a waiver form that requests a special DEA number for your ability to provide office-based buprenorphine treatment for substance use disorder. And then once the waiver is accepted, the DEA issues you a provider identification number, which, at least in most cases, is your DEA number, but with an X in front of it. How many people can you treat? When you have your waiver at first, for the first year, you can treat 30 clients. After that, you can request the ability to treat up to 100 clients. And what you can expect is a visit by the DEA. This is in the waiver request form that you submit. I myself was surprised to have the DEA visit my office a couple years after I started prescribing buprenorphine for patients, and I thought I was singled out, but it turns out there is a list of all waived providers, and randomly they bring up your name, and if you are the name brought up, they come to your practice. And really, having met with the regional DEA officers here, their intent really is to make sure that the drug is going where you're prescribing it. They want to know that you are putting your X number on your prescriptions and that you are keeping track of the patients that you are prescribing to, and that if you happen to be in a clinic with a pharmacy where you or the pharmacy is dispensing the buprenorphine, that you account for every dose. Really not unreasonable expectations. They are not interested in clinical practice. They made it very clear. They have no role in that. They really are interested in making sure that the medication is being dispensed properly and goes where it's supposed to go. So given the fact that there has been an increase in opiate-related overdoses and deaths, that there is this medication available for people with opiate use disorders. We at the Healthcare Authority sort of put our heads together and said, what are some of the things that we want to be able to do to get a better handle on this and better help support people with opiate use disorders? One of the things we did is we looked at the prescription monitoring program, and we looked at patients who had Medicaid who were also getting opiate prescriptions or other controlled substance prescriptions by paying cash. And what we wanted to do was to let the managed care plans who care for those folks know that they need to have they need a little bit of case management or more focus. And we also wanted to alert the pharmacies that they are not supposed to take cash for clients. So wanted to kind of make sure that we had a handle on what people were taking, and if they were at high risk for abusing opiates through multiple prescribers, that they were assigned a case manager or care coordinator by their plan. We then, as mentioned, let the plans know. We also notified providers who had patients who within the last year had an overdose event or some significant opiate-related sequela, that their patients had that. We looked at hospital data, emergency room data, and for the patients who were identified on Medicaid as having had an opiate-related sequela event, we submitted letters to their providers and let them know. Some knew, some didn't, and so again, just trying to help folks identify people who may be struggling with substance use disorders. Then the last thing that we did was we surveyed through SurveyMonkey the provider community on barriers to prescribing buprenorphine. This is, again, a busy slide, but themes that were pretty consistent throughout the survey were that access to treatment and even buprenorphine providers in rural areas is a challenge. There are often long wait times to get an assessment for treatment or to get into treatment. There really aren't enough medical detox facilities for folks on Medicaid, and that if you're not able to help someone who at that moment in time is ready either to enter detox, which is now better termed withdrawal management treatment, or treatment, that window of opportunity may be lost. And so really fairly consistent themes in terms of barriers. Again, rural areas and even urban areas, folks don't necessarily have access to transportation, and they may not be ready to enter formal treatment, particularly for women who may be a single parent and have kids at home. Going to wait 60, 90 days of inpatient treatment isn't an option. So really trying to think about ways to reduce these barriers and ways to help better support patients with substance use disorders. There were a number of recommendations from people completing the survey for us to better address the large increase in heroin use and opiate use across the state. Was to, as I mentioned earlier, allow nurse practitioners to also prescribe Suboxone. Right now only physicians are able to prescribe it through a waiver. Incentivize providers and health plans to prescribe and cover buprenorphine use. Make the paperwork process currently in place a little bit easier. Establish clear criteria for use. Make sure that people understand the role and advantages of buprenorphine. Folks felt like they needed more staff. Their staff needed more awareness to help support this effort. Rural communities need more access to a number of resources, and certainly more mental health resources to help folks who are often also comorbidly affected by mental illness stay supported in their efforts at recovery, and really more access to treatment. We took some of this feedback and actually had been receiving it for a while, but really wanted to maximize the opportunity for patients on Medicaid to be successful in their management of their substance use disorder, recognizing that it is a chronic, relapsing, remitting disease. One of the things that we did was remove the 12-month lifetime restriction on buprenorphine, and there is now no longer a lifetime limit. There is also no longer the requirement, though it is certainly encouraged, and for people who continue to struggle once on buprenorphine maintenance, urged, is people do not need to be in concurrent DSHS certified treatment in order to be started on buprenorphine and continued on buprenorphine. Really want people to have their best chance at stability, clear thinking, in order to best help chemical dependency professionals, their primary care provider, their addiction medicine provider, help determine the supports that they need in the order in which they need them and how they best can achieve sobriety, recovery for themselves. Other changes, I kind of went over these earlier. Buprenorphine monotherapy, really it's only covered for women who are pregnant. We will only dispense a week at a time, again largely for its abuse potential, and a person needs to either have DSM-4 criteria for opioid dependence or DSM-5 criteria for the moderate or severe opioid use disorder I went over early. Buprenorphine naloxone or Suboxone covered for anyone over 16 with the same criteria. And then again, the requirement for treatment in a DSHS approved facility, while encouraged for folks receiving medication-assisted treatment, is no longer a requirement. Certainly people who aren't able to maintain a reduction in their use of opiates, cessation of their use of opiates while on medication-assisted treatment, are not able to better stabilize, should absolutely be referred for evaluation by a chemical dependency professional or an addiction medicine physician or other practitioner for evaluation for the need for a higher level of treatment. And sometimes that may even be referral to an opiate treatment provider where they can be stabilized with daily doses of methadone. So again, no lifetime limits. People may stay on buprenorphine for as long as they need it, similar to folks and their need for methadone. Lowest dose necessary should be prescribed. Most people do fine around doses of 16. There can be times at which higher doses are necessary. Other use of controlled substances is best managed between the patient and their provider. It will not be an automatic reason to stop someone's Suboxone or authorization of it. However, continued use of another substance or inability to decrease or stop using opioids should be a trigger that that person needs additional evaluation and or more supports and treatment. No more than 3 buprenorphine inductions in a calendar year will be involved if that person is under the care of an addiction medicine physician or a chemical dependency treatment agency, and that's their recommendation. Certainly that will be considered. Buprenorphine will not be approved if there has been evidence that the patient has been diverting some or all of their buprenorphine and or selling it to others. We ask and we'll ask that you keep a nominal record of this in your charts, that before you start someone on buprenorphine, and periodically, and really you should do this anytime you write any controlled substance, that you check in the prescription monitoring program to see if that patient has been seeing other providers and having other controlled substance prescriptions. And then also want to have folks be monitored appropriately through urine drug screening, but there's no longer the requirement to submit a completed lab form every time a new prescription for buprenorphine is requested. For questions and resources and tools, there are some websites that are available here, which include our criteria and forms needed to request buprenorphine. For any questions regarding the clinical policy, please feel free to contact me. There's my email address. And for questions regarding the authorization process or operational policy, please contact the Apple Health Pharmacy email address there. As of October, all of the authorizations for buprenorphine prescriptions will be turned over to the managed care organizations. We at the Healthcare Authority have been working with them for the last number of months to help get ready for this transition and make it as seamless as possible for patients. We want people who have substance use disorders, in this case we've been talking about today opiate use disorders, to have their best chance at success in managing this chronic disease. We want them not to have barriers. We want to be mindful of how we're providing care to them being good stewards of resources, but also recognize that with any chronic disease, it's a challenge to manage it, and we want to do our best to help support your efforts as providers across the spectrum of disciplines in caring for patients who are covered by Medicaid, and want to thank you for doing that. I also want to thank Amanda Avalos, who was instrumental in putting this together, as well as the survey, collating all the responses, summarizing them, as well as the excellent folks in the pharmacy who've really made this transition a deliberate process that hopefully in the end will make access to medication-assisted treatment easier and better for patients.